I wear a lot of hats, a number of hats at OSU. I'm an administrator leading the Department of Urology. I'm an educator, teaching medical students and resident physicians to be leading urologists. But importantly, I'm a surgeon of over 16 years, trying to cure patients of bladder cancer. With all that experience, though, there are still times when I cannot provide patients with the right treatment at the right time and for the right person. Why is that? Well, generally, our treatments for our treatments for bladder cancer are pretty clear for patients who have very low-risk disease that will never threaten their life. And also for patients who have very serious high-risk disease. But it's the patients in the middle that are difficult. And I'll tell you, the decades-old tools that we have been using to try to assess the risk of these cancers is often insufficient to help us advise patients of their risk and also what treatment they should undergo. Let me demonstrate this for you. I recently saw a patient at OSU, a middle-aged gentleman who was a previous smoker. He had blood in his urine, and of course he was alarmed by that. He didn't know, like so many others don't know, that smoking causes bladder cancer. Half the people with bladder cancer are prior smokers, current smokers, or have had significant secondhand exposures. So he saw his family doctor, and the family doctor said, "You've got blood in your urine. I'm going to send you to a urologist," which he did. That urologist obtained some x-rays, a CAT scan. He also looked into his bladder with a small telescope and found a bladder cancer. Now, the CAT scan suggested a serious tumor, and so he referred him to me at OSU. I spent some time talking to the patient to tell him we need to understand the personality of this cancer and the character of it so we could understand its behavior and find the right treatment. Part of that meant taking a sample from that tumor and sending it off to the pathologist for evaluation. I took him for a small surgery. We took some of the tumor. We sent it to the pathologist. And the pathologist said, "I can't tell you what the extent of the cancer is. I can't see some of the typical landmarks I'm looking for. I need more tissue." So we went back for a second surgery. During that surgery, I took more tissue, deeper tissue, and I started to become more concerned about a deeper cancer. I sent it off to the pathologist, and he said, "Guess what? There's almost no tumor left." So you can imagine that this left us with some questions. The x-rays suggested a more advanced disease. My impressions were beginning to align with that, but the pathology wasn't supporting that. So that left us as one of those middle patients, and as I tried to advise him on his treatment options, that meant there was a wide array of treatments, from things that were conservative and to treatments that were aggressive. The conservative treatments meant he could keep his bladder, but if tumors came back, we'd have to go into the bladder and remove them, and perhaps even instill chemicals into the bladder to reduce the chance of those tumors coming back. The other side of that was a very aggressive treatment involving radical surgery that we all know is serious and has its own risks. Of course, he opted for conservative treatment, but I was nervous about that, because 1 in 4 patients with the stage of cancer that he has, treated conservatively, will have those tumors come back at a deeper stage and more difficult to treat and cure, meaning that we might lose our window to cure this patient. Additionally, patients with this stage, we worry about underestimating the cancer. 40% of the cases are actually understaged. So we think we're at a middle patient, but in all reality, they're more advanced. And in the meanwhile, we're using a conservative therapy that will never help. The tumor progresses, and again, we're losing our window for cure. So perhaps we should just treat everybody aggressively. But radical surgery means removing the bladder, other organs, and that is associated with a high complication rate. We have to revise the urinary system, and that has real implications for the quality of life of patients. So you can imagine that these issues weigh heavily on the 79,000 plus patients who will be diagnosed with bladder cancer this year. None of them want to be part of the 17,000, none of them want to be part of the 17,000 who will also die of their disease. We can do better for our patients. We can. Some of the research that I'm going to talk with you about today, conceptually, may help us rethink how we view pathology, how we assess risk, how we think about the extent of cancer, and how can we address some of the challenges that we face in what we currently do. What do we do now? We see a tumor in the bladder, like you might see here. We remove that, I would remove that, send the tissue to the pathologist. They take a section of that, they stain it, they look at it under a microscope. They take some areas that look normal, they take some areas that look cancerous, they compare cells in each group. They look at the cell size, they look at the associations with other tissue around it, and they try to make an assessment of how threatening this cancer is. It works a lot of the times, but there's problems. First of all, the pathologist can only review what I send her or him. And there are sampling errors. In our patient, the pathologist said, I can't see the regular landmarks I'm used to seeing, so I can't tell you the extent of the cancer. In addition, the pathologist is looking at cells and comparing cells, but there's millions of cells. It's humanly not possible to look at all those cells. And perception matters. There is a subjectivity to this reporting, as Dr. Retchen was talking about, so that the environment of the cells and how they're presented will impact and influence the reporting. How many logs do you see here? Is it 4 or is it 3? Perception matters. Well-trained pathologists can look at the same specimen and see something different. But that's problematic when you're trying to cure patients of their cancer. We need tools that are going to be more quantitative and remove the subjectivity out of these kinds of assessments. Our research team did an interesting experiment. They gave pathologists different tissue sections to look at. The pathologists gave their reports, and then unbeknownst to them, the research team gave them back the same specimens, but only reoriented by 90 degrees. 1 out of 5, or 20% of the pathologists, reported something different. It's because orientation makes a difference. The work that we've been doing primarily involves image analysis and machine learning. That means taking those images that we were just looking at, that the pathologist would see, taking those images and training a computer to view what's important and learn about those images, but let it keep going, to learn beyond what the eye can see, to think about different patterns that could help us understand those tumors in a better way. Let me give you an example of that. Here's a section, a color section, that a normal pathologist might look at. Well, we can use the computer, train it to see what the pathologist is seeing and know what's important. Look at the size, look at the shape, the associations. And the computer can keep learning and keep understanding what the pathologist needs to see. But the computer doesn't stop there. It automatically keeps learning, and it's associating and developing all types of features. And these are some of the examples that you're seeing in the gray tiles. Different patterns that don't make a lot of sense as a human looking at this, to our human eye. But the computer is setting up feature after feature, and from that one color slide, it generated 100,000 features automatically. So that we don't need to rest our assessments on one landmark of tissue. We don't need to rest on a few associations. We can look at all of these patterns being developed and created by the computer to categorize these patients in different ways that make sense, or that will be important for us to understand the extent of cancer, the assessment of the risk of the tumor, and ultimately help us devise better therapies or apply different therapies for our patients. Now, we're not trying to put pathologists out of business. What we'd like to do is increase their capacity, have them understand that there is certainly other patterns and features that we can use on top of what we already know. Now, my patient did not have access to image analysis or machine learning. I had to use the tools that I've used for many years, and I suggested an aggressive treatment for him. Ultimately, we found that he was one of the 40% of people that we underestimated his cancer. And although we subjected him to radical surgery and significant recovery, that probably saved his life. So I can take comfort in knowing that this time I got it right. But the research we're doing now, I suspect, is going to help urologists like me get it right every time. Thank you.
That was a great story, Cheryl, and though you're not putting pathologists out of business yet, you're probably not going to be an invited keynote speaker at a pathology convention. But seriously, tell us a little bit about, with the machine learning, do you see this perhaps being applied to other cancers? The power of the supercomputer, like we all read about IBM Watson, is that what you're doing?
This is what the whole team has been doing. And in fact, we didn't have time to talk about all of what's been going on, but this group has looked at this extensively in lymphoma already. And as we bring this to bladder cancer and other solid tumors, the sky's the limit. What I think will happen is that we may be able to use this type of technology, and we don't have to use it in isolation. We can partner with some of the known demographic factors or patient factors that we know about. We can use molecular characterization in the genome to help us even think further. We can use all these powerful tools and harness this together to be able to be more precise about our treatments for our patients. So yes, the answer is yes.
That's great. Another big round of applause. Thank you, Cheryl.